Hi everyone. In this masterclass, I will briefly take you through the diagnostic devices used in a dry eye disease, their role in a dry eye clinic, and most importantly, how the information they provide translates into day-to-day clinical practice. Let's start with the diagnostic armamentarium available to us. On the comprehensive end, platforms like ocular keratograph and the intraocular surface analyzer gives us topography, the non-invasive breakup time, and the mammography in all one sitting. The LipiView is a purpose-built for lipid layer thickness and mammography. We can use anti-segment OCT to give us tear meniscus site and meibomian gland imaging. And also, the in vivo confocal microscopy helps us to look at the corneal nerves at a cellular level. And if none of those platforms are available, you are not stuck. The trans-elimination meboscopy is just a slit lamp and the trans-eliminator, which costs nothing extra. You can also retrofit your existing slit lamp with an infrared filter and camera for infrared mebography. Even a smartphone with a clip-on infrared filter can imagine the glands. And if we already own an anti-segment OCT, we can repurpose it for mebography without buying anything new. Let us look more closely at the keratograph and LipiView, which is available at our institute. Keratograph is a corneal topographer at heart. It projects a ring pattern from a Placido disc onto the tear film using an infrared light source and captures the reflection, thereby allowing us a comprehensive assessment of the tear film and the meibomian glands. Let us walk through the report layout from top to bottom. The Genvis Pro Dry Eye Report is an integrated dry eye analysis software. It combines objective ocular measurements with patient-reported symptoms into a single, easy-to-interpret report which helps for diagnosis, patient education, and follow-up. Here is how the actual report looks like. At the top, we have the patient details, followed by a diamond-shaped overview, which gives the glance overview of the report. The more the diamond skews red, the more abnormal is the parameter. Then we have a tear meniscus height component, which is mentioned below in this image. The tear meniscus height is usually calculated manually. After the image is captured, the examiner will use calipers to measure the tear meniscus height. The next comes the NAKBUT, which is non-invasive keratograph breakup time. We can see where the breakup starts and how it spreads across the entire cornea. It is color coded from green to red. Keratograph gives us two breakup time. The first breakup time is the first detectable tear film breakup after a blink, and it also shows the area where it starts. Then comes the average NAKBUT, which is the average breakup time across the entire cornea. The first NAKBUT is often more clinically important because it detects the earliest loss of homeostasis. Next comes the interferometry. It uses interference pattern from the lipid layer. The machine grades according to the color hue as mild, moderate, severe. Interferometry indicates the lipid layer thickness. Then comes the mammography. Mammography is a non-invasive infrared imaging technique used to visualize the morphology of the meibomian glands, above the lids, and there is automatic grading. Grading as follows: grade 0 no loss, grade 1 33% loss, grade 2 66% loss, and grade 3 is total loss. It is followed by redness grading, which is also color coded and is graded automatically. Coming up next is another important device used in our dry eye clinic, that is LipiView 2 interferometer. It gives us the blink dynamics, lipid layer thickness, and mammography images of the eyes. The LipiView interferometer records a 20-second video of the tear film interference pattern and subsequently displays data in interferometric colored units, that is ICU, where one ICU reflects approximately 1 nanometer of the lipid layer thickness. So studies consider greater than 60 nanometer of lipid layer thickness as near normal. The LLT can be influenced by various factors like meibomian gland dysfunction, blink pattern, and ocular surface disease. The lipid layer thickness can be normal or even increased in meibomian gland obstruction or in aqueous deficiency disorders due to a stagnant membrane. So always interpretation should be combined with the clinical picture. LipiView also analyzes blink dynamics. Why blinking is important? Because blinking is essential for spreading the medium uniformly over the tear film. It gives us the total number of blinks a number of complete and incomplete blinks. For example, in this report, the total number of blinks is 2 and there are no partial blinks. Whereas for the left eye, there are total number of blinks is 6, there were no incomplete blinks. Why incomplete blink is important? Because during an incomplete blink, eyelids fail to close completely, the mebum expression is reduced, and the lipid distribution becomes uneven. The C factor, also known as the confidence factor, is another important component of this report. C factor indicates the reliability of the lipid view by assessing how closely the measured interferometric colors match the predicted color scale. C factor more than 0.08 indicates a reliable measurement. A value less than 0.08 should be interpreted cautiously and the test should be repeated. The lower part of the report shows the infrared meibography. It is similar to the meibography in keratograph. Normal glands appear as long, vertical, parallel, extending across most of the dorsal plate as shown in these images. Let us see some case examples. This is a 58-year male with a best corrected visual acuity of 6.6 in both eyes. He presents with meibomian gland dysfunction characterized by frothy discharge, cheesy secretions, which will be shown in the next slide. The Shermas was 12 in the right eye and 10 in the left eye, and the tear breakup time around 6 and 5 seconds, respectively. So on slit lamp examination, there are evidence of meibomian gland dysfunction with a frothy tear film and thick cheesy secretions. The meibomian gland remain expressible with thick secretion. So here is his keratograph report. The diamond report for the both eyes is shown side by side. Notice how the shape is skewed towards the abnormal parameter, like there is a shape reduced along NAKBUT time, which is consistent with MGD. The tear meniscus height of this patient is within normal limits, and the NAKBUT pattern, note the early breakup patterns. The first NABUT and the area of breakdown is around 9 seconds, and the average NAKBUT for the right eye is around 9.75 seconds. Similarly, in the left eye, first NAKBUT is 7.5 seconds, and the average is around 9.35 seconds. Reduce. And then the interferometry grading. The lipid layer pattern here is graded as moderate. The interference pattern lacks the dense color bands expected in a healthy lipid layer. And here is the mammography, which shows mild gland shortening and early dropout. And there is mild redness according to the Genvis scale. Here is this lipid layer dynamics along with the mammography images. The lipid layer shows increased thickness can be due to stagnant sebum and unstable tear film. Mammography also shows mild gland shortening and early dropout. The gland morphology is not affected much, so these patients usually respond to warm compress therapy or lipid therapy. So here is the keratograph of a meibomitis patient with a grade 3 meibomian class loss. So these patients usually don't respond well to warm compress or lipidotherapy. Thus, this meibography helps us to understand the disease as well as choose appropriate therapy for the patients. So our second case is of a secondary Sjogren syndrome, a 45-year female with a best corrected visual acuity of 6.6 both eyes, with Shermer's 4 mm in the right eye and 5 mm in the left eye respectively. Clinical on clinical uh, on clinical examination, she was having conjunctival staining in the interpalpable area in both eyes. There was no cornea staining. The keratograph report as follows. The diamond overview report highlights the impaired tear meniscus height and NAKB values. The tear meniscus height is reduced and an impaired NAKBUT with the first breakup time around 3 seconds in both eyes, an average 4.45 in the right eye and 3.4 seconds in the left eye. Our mammography shows grade 1 loss in the right eye and grade 3 loss in the left eye. So she was under care of rheumatologist for a systemic control. Along with that, she was prescribed topical lubricants and topical immunomodulators. Our third case is a 50-year female with a Stevens-Johnson syndrome. Her vision is 6:12 in the right eye and 6:15 in the left eye. Clinical examination shows diffuse staining pattern in both eyes with presence of corneal scars. Her Shermers were around 2 mm in both eyes. So this is a lipid layer report. It should be interpreted cautiously in these patients as a thick lipid layer thickness in severe SJS or aqueous deficiency dry eye does not indicate a normal meibomian function. Reduced aqueous volume or impaired tear clearance and accumulation of stagnant venom can produce an apparently thick lipid layer despite the severe ocular surface disease. Here is a diamond report for both the eyes. We can see a skewed report in both the eyes as shown. The tear meniscus height is significantly reduced. So the NAKBUT, we can see the breakup occurs almost immediately after blinking, indicating a profound tear film instability and ocular surface irregularity and severe tear instability, and the reduced tear volume has affected the interferometry reflection pattern in this patient. This is a ramibography showing significant gland drop and the moderate redness grading as per Jenny scale. So she underwent punctal cautery along with frequent and she was continued on frequent topical lubricants. To summarize, no single investigation diagnosed all forms of dry eye, combined symptoms, clinical examination, and objective imaging for accurate diagnosis. Objective imaging helps us to personalize treatment, monitor response, and educate the patients. Until next time, keep learning and keep digging deep into the surface. Thank you.